So my topic is going to be looking at ulnar-sided injuries with fractures, which is actually, I think, really kind of fun. It's a little bit easier than dealing with some of the chronic pain and so forth that comes in later. But in any case, I think what we want to do is think about when the radius is reduced and then the DRJ is unstable or there's an ulnar fracture, what are we going to do? And thinking about everything Dr. Berger taught us and reviewed with us tonight, the ligaments and the TFC, think about the ulnar-styloid fracture and does that matter? And what about the distal ulnar fracture? Do we need to do anything about that as well? So the goal for my portion is just to kind of discuss that we want to make sure we can identify the injuries to the DRJ and detect that instability, as Dr. Mario showed, also trying to really, by that exam, and then treat that instability along with the distal radius fracture. Keeping in mind that the DRJ, again, requires motion and stability, and that's a balance of the bony and the soft tissue constraints that Dr. Berger reviewed, as well as that we know injury to these ulnar structures is very common. And if we can get it stable and keep it there, a lot of these can heal very nicely. So imaging is important. These are some really obvious examples of when things aren't going so well, when you can see the diastasis of the DRJ. This is actually an ulnocarpal, radiocarpal dislocation, as well as a radioulnar joint dislocation. But sometimes it's not quite as obvious. And we do use other imaging, such as the CT showing a large sigmoid notch, almost a subchondral sigmoid notch fracture, and that may or may not be caught by our volar plates. And that could give you instability as well. So it's nice to know what you might be going into ahead of time, looking out for marginal fractures and other severely common fractures of sigmoid notch, for instance. MRI, certainly, if I'm going to speak more from the idea that you're treating these at the time of the surgery with the distal radius fracture for now. So MR and arthroscopy you might consider, or they might be down the road if you're having trouble later. But I think one of the first things we have to talk about is making sure that the radius is actually reduced. And this includes making sure that the coronal plane correction is complete. Dr. Wolf and many others have talked about this, but the bottom line is that if we can make sure that we correct the coronal plane here, this helps put everything back where it belongs, including the TFCC and the ulnar-styloid, and retensions to any tissue down at the distal ulnar of the radioulnar joint, in particular the distal interosseous oblique ligament, although not everybody has that. Nonetheless, getting this space tension is helpful. We achieve this by lifting the shaft of the radius with the white arrow, and then ulnarly deviating and making sure that the intermediate column or the volar ulnar corner of the radial metaphysis is reduced. This helps restore the sigmoid notch alignment, as well as the tension of the interosseous ligament and soft tissues, and again allows the styloid and the TFC to at least be in the vicinity of where they belong. So does it matter if the ulnar styloid is displaced or not as far as outcome? Earlier on and somewhat before volar plating, it was thought that these mattered probably a little bit more, but there have been many reports that show that volar plating is probably protective, and that the styloid fractures themselves can be largely, I wouldn't say ignored, but you don't have to absolutely fix anything unless the DRJ is unstable. So we tend to recommend treatment only if there's instability of the DRJ after the radius is reduced anatomically and is stable as far as fixation. However, don't forget that you can have instability of this radioulnar joint without a styloid fracture. And in this study, it showed a greater incidence of instability without a styloid fracture. So in any case, just make sure once we have the radius reduced, we're going to check that radioulnar joint and treat it if it's unstable, regardless of whether the styloid fracture is there or not. So if we're on the left side of this screen and we fix the radius and it's stable, that's great. We might splint it in neutral. We prefer to splint in neutral. Almost all of us here will do that. So we minimize any coordination or supination contractures. If it is unstable, we have some other things we can talk about: pinning the bones together, or suture repair, or styloid repair, or an X-fix if you really want to get into that. And if it's not reduced or irreducible, you need to go get the things in the joint, out of the joint, or again, make sure the radius is reduced. Otherwise, you won't ever get to the right goal. So if there's instability, as Dr. Berger talked about, we consider this, if there's instability, we can think about either pinning the ulna to the radius or do the open foveal repair or the styloid ORAF. You can choose to do this how you like or what you're comfortable with. There's no superior evidence for one versus the other, but certainly there are some of us that like one way versus another. Most of us here will consider fixing the fovea or the TFCC and the styloid if necessary, because it allows us to maintain stable position in a neutral rotation splint. and we don't have to deal with other positions that might risk stiffness. This is just an example of the X-Fix. If you should need to do it, you certainly can. I think it's a little bit involved, but can do it. 4K, if you use K wires, we like to use 6-2K wires and go through all 4 cortices, because these K wires do this and they break and they get loose. And this way, at least you can get them out if they break. And so you want to make sure and that's even in a long arm cast. My experience has been that these break in fatigue. So I really don't like this method unless I'm really pushed up against the wall, but beware of the usual ways it'll fail, so you can get them out at least. More commonly, we will do a dorsal exposure through the floor of the 5th compartment with K-wire holes through the ulna and into the fovea, and then using sutures through the TFC and then back through the bone tunnels, which are the red lines here. It allows good visualization of the joint. This is an example with the fingers to the left, elbow to the right, 5th compartment. We can find the tendon, pull it aside. Here's our capsulotomy with the tendon pulled aside. We can explore the DRUJ here. We want to be careful not to go too distal with this and not cut the dorsal radial ligament. And if you need to, you make another window distal so you can suture back, or if you use a scope, you can do a combined approach, of course. But this allows excellent exposure, and we can do our open suture repair that way. Now, some cases come a little different. This was a very severe Galeazzi fracture that also had a segmental radius fracture here and here. And we had to treat this, of course, and we needed a dorsal incision to get all the extensor tendons out from between the radius and the ulna, a long plate to span both fractures, and then a limited dorsal suture repair in this case. I didn't fix the whole styloid. We were able to just tack things back down, and a little bit less than I normally would have planned, but that worked out well, probably because we also had good stability of the radius. Another example here, Galeazzi's just are easy to talk about here, but just to mention, if you have the Galeazzi like this and this is exposed, it's an easy access to go ahead and put a suture anchor in, and you can set up your suture anchors and then fix the radius and pass the stitches and then kind of tidy it all up when you're done. This resulted in good rotation, good stability of this Galeazzi fracture. So if you're going to go to the styloid, you certainly can make sure you can do an open reduction. You can do a closed reduction and pin fixation. Just protect the sensory branch of the ulnar nerve. It's something that you can't make go away if you injure it. And it really doesn't matter. I don't think Dick is still, I'm not sure if he's still on the call, but he taught me to use a K-wire and a suture figure 8, because we used to use wire and then we'd see the wire break and have to explain that to the patient, even though they were asymptomatic and healed. So just using a large suture and even a bone tunnel, if you need to, just on the side of the ulna is good for figure 8 to repair that. And then you don't have too much bulk there. This is a picture courtesy of Dick as well, just showing an ulnar-sided approach. This is you can fix the TFC and the styloid, of course, through that approach, and make sure we protect that sensory branch of the ulnar nerve. You can fix these any way you like. If you want to use a pin plate construct, whichever, just make sure you try not to irritate the sensory branch. If you go onto an ulnar head and neck fracture, if these are minimally displaced and the distal radius is stable, you don't have to do much about them. We splint them in neutral. For 3 or 4 weeks, they get stable and you can start to rotate them gently. Most of them will feel very nicely, as you can see in this case. This is an older case of mine, X-Fix and pins for distal radius fracture. Didn't treat the ulna at all, except splinted her. She had good rotation, healed very nicely. More recently, we use volar plates and go on to this one. Looked pretty good with our distal radius reduction. We splinted the ulnar head. It's a little bit displaced, but she has good rotation and a nice union and no convergence of the radius in the ulna. If you have a displaced intra-articular ulnar head fracture and it's significantly displaced in a younger person, you may go ahead and fix that through a dorsal arthrotomy, as I showed through the 5th compartment. I will try to do as much as I can from the outside, from the ulnar side if I can, but if you need to go into the joint, you can go through the floor of the 5th. One of the things, we've used small locked plates, 2mm plates. These can be used pretty nicely if you need to stabilize the ulnar head and neck. I think you should really only do this if you really feel that ulnar head and neck unstable and it's crunching and just not really behaving once you fix the radius. One of the things I'd like to share with you, though, is that this technique works pretty well, but be careful that you don't go into the ECU groove with any of your pins from the side or from the bottom. That can cause a problem. And you definitely don't want to be in the sigmoid notch with your screws or pegs. So just be careful and make sure you take good oblique images as well. The main thing I wanted to leave you with is that just as much as correcting the radial, the shift of the, or the coronal plane of the radius. If you have a fracture like on the left here where the ulnar shaft is basically kind of converged with the radius, it's important, I think, to get them apart again. And this is an example where one radius is pretty comminuted, but we fixed the radius and it looked pretty good. But you can see how the ulna has collapsed against the radius here. And I think equally, like we would correct the radius, we can use a plate and we can then restore that bow and get the space between the radial ulnar space back. And I think that does help put everything back under good alignment and possibly some tension that may protect the radial ulnar joint and stability. So just something to think about in case you haven't thought about it from the ulnar side versus the radial side. So in my few minutes here, I would say make sure you understand the injury from the instability, imaging that can help. You know, a few ways to stabilize the DRJ, whether it's pin, X-fix, or our preference is probably open it and fix it. And then we prefer neutral rotation splints to try to avoid pronation or supination contractures. Thanks very much.